Welcome back to Cycle Wisdom, where we empower women to restore natural menstrual cycles to improve health and promote fertility. I'm your host, Dr. Monica Minjeur, and I'm so glad you are listening today. Today, we continue in our series of episodes focused on PCOS, or polycystic ovary syndrome. Since September is National PCOS Awareness Month, I am focused on creating educational content in an area that is otherwise lacking. PCOS is often not appropriately diagnosed nor treated, and in many clinics, the supposed standard of care is prescribing oral contraceptive pills rather than treating the root cause and addressing other lifestyle and health factors. On today's episode, we're going to talk all about PCOS and its implications for fertility and pregnancy. We have many women who come to us because they have been told that their PCOS diagnosis is going to make it difficult or even near impossible to try and achieve a pregnancy. The statistics out there are that 70 to 80% of women with PCOS will struggle with infertility. Now that's a huge number, and I want to let that sink in a bit. 70 to 80% with PCOS will struggle with infertility. But there is hope. This is why it is crucial to work with someone who fully understands PCOS, especially if you are planning to try and achieve pregnancy, even if that time isn't right now. I want to work with you now to address underlying causes to improve your chances of a successful pregnancy in the future. When we treat the root cause and address the individual issues that you have with your cycles, we can significantly increase your chance for a successful and, more importantly, a healthy pregnancy for both mom and baby. So let's start off, as always, with a patient story about Ava. Now, Ava came to me and she was 35 years old. At this point in time, she had been dealing with infertility for about 6 years. She was having irregular cycles only 3 to 4 times a year and had been appropriately diagnosed with PCOS. During these past 6 years, her primary care provider referred her on for artificial reproductive technologies, stating that that would be the only way she'd be able to get pregnant with her PCOS. Along the way, Ava went through 5 rounds of intrauterine insemination, as well as 3 rounds of in vitro fertilization. These treatments were not only very expensive, but they were also incredibly emotionally draining. She did have 1 pregnancy along the way with these treatments, however, ended up with a miscarriage at about 6 weeks along. By the time Ava came to see me, she had actually taken off the past year from trying to get pregnant because she was so overwhelmed and exhausted with all the treatments that she had been put through without any real reason as to the underlying cause and without any successful long-term ongoing pregnancy. So as always, our first focus was on treating the root cause of Ava's infertility, which in her case we knew was PCOS, but also suspected there may be some other issues going on as well. So we got her started with charting her cycles, we ordered lab work timed to her cycles, and then started this process of hormone balancing, targeted ovulation treatment, as well as evaluation and tracking of her follicle development with her cycles. And what we found was that yes, Ava had these anovulatory and irregular cycles because of the PCOS. But because of this, we also found she had excess estrogen as well as excess testosterone. Additionally, she had a thyroid dysfunction problem, as well as some insulin resistance and some weight problems with some mildly elevated blood pressure as well. So right off the bat, we know we're dealing with some menstrual irregularities, obviously some fertility problems, but we also know that we're seeing the effects of PCOS as well as these chronic health conditions playing a bigger role in Ava's health long-term, even independent of her chances for getting pregnant. So from the start, we started Ava working with one of our health coaches. We adjusted her supplements. We talked about those lifestyle changes to help reduce her stress, reduce her problems as far as the weight goes, tried to help work on the diet, some increased activity, and also got her started on the correct treatments that she needed from a prescription standpoint. Now, this is not easy, and it is not for the faint of heart, and it does take some time. But the way that I look at it is that we say, hey, this is going to impact your long-term health. This is not just that easy fix. And as we continued to monitor her levels, making adjustments over time, Ava was able to achieve a natural pregnancy after 7 cycles without needing any artificial reproductive technologies. Most importantly, we continued to monitor Ava's hormone levels throughout her pregnancy to make sure that she had enough progesterone and enough estrogen, and added additional prescriptions and supplements when needed. She was able to not only avoid miscarriage, but go on to have a healthy pregnancy. Now, as you remember, prior to pregnancy, Ava was dealing with insulin resistance and elevated blood pressure issues. But because we had addressed those issues prior to pregnancy, she actually did not have any problems with gestational diabetes. She had been able to improve her weight, her diet, and her insulin resistance prior to conceiving, did not have any blood pressure issues or preeclampsia, and went on to deliver a full-term healthy baby girl who was 8 pounds, 2 ounces. So how do I know if I'm going to have a problem? I've been given this PCOS diagnosis. Am I going to fall on the side of that 70 to 80% of women who have troubles? Or am I going to be in the camp of 20 to 30% where I don't have any issues at all? The biggest thing that we look at is we're looking at the charting of your cycles. We can oftentimes identify by looking at your mucus patterns or temperature shift or urinary LH levels to be able to see, does it look like you might be struggling with some ovulation dysfunction? We also will always get blood work, again, timed to your cycles in order to assess for adequate but also optimal levels. It's not just enough to say, yeah, my labs show that I've ovulated. We want to make sure that that ovulation is optimized prior to achieving pregnancy to help reduce your risk of miscarriage. And most importantly, we want you to get treated before pregnancy to limit your risk factors during pregnancy. As was the case with Ava, we wanted to address those other underlying health conditions so that not only was she able to achieve pregnancy more easily, but she was also able to have a more healthy pregnancy for both her and baby. Now, this is all incredibly important to address these risks ahead of time because we know that women with PCOS do have increased risks during their pregnancy. Now, the most notable risks is that they are 3 times more likely to have gestational diabetes. They are 2 times more likely to have preterm birth. And there is also a significant increased risk of miscarriage, higher chance of baby landing in the NICU after birth, larger babies, and an increased risk of C-section. And so when we treat all of these things prior to getting pregnant, we know that we have decreased risk with all of these. In fact, in our practice, we have much less issue with any of these problems because we are addressing the underlying causes prior to pregnancy. We are correcting any underlying hormone imbalances. And most importantly, we are addressing those lifestyle modifications to make sure that we're going into pregnancy as healthy as possible. And we've already set that good groundwork for having the good lifestyle changes made so that we're not struggling to try and catch up after a pregnancy is achieved. So why do women with PCOS have troubles getting pregnant in the first place? The primary issue we see is because of that anovulation or the irregular cycles. So if you're not ovulating, whether that's from insulin resistance or just the PCOS in general, if you're not ovulating, obviously you can't get pregnant if you don't ever release that egg. And so this is why it's incredibly important to be seeing if you're having regular cycles, but also are we observing the other biological signs to show that ovulation is happening and backing that up with our lab work each cycle in order to confirm that ovulation has happened. Now, charting is great, labs are great, but it is not going to be confirmatory that an egg is actually being released. So there is something called a luteinized unruptured follicle, and this happens when you have a follicle that's developing around that egg that's going to be released. The hormone levels surge like they're supposed to, your biological signs happen like they're supposed to, and everything appears to be fine, but that follicle may not actually open and release that egg, and that's that luteinized unruptured follicle, or we call it a LUF. Now, we can see LUFs happen commonly with PCOS, and so this is why it's incredibly important to make sure that we are documenting an ultrasound that happens not only before the ovulation occurs so that we can see the developing follicles, monitor the size of it, but also to check after we see those ovulatory signs on the biochemical levels, on the lab levels, we recheck that ultrasound again to make sure that that follicle has opened or ruptured and released the egg. So that's the only way that we actually know if ovulation has occurred, by seeing it and documenting it on ultrasound. So treatment, again, I would refer you back to last week's episode where we talked all about the different treatment. But again, when it comes to pregnancy, when it comes to fertility in general, the main tenets of treatment with PCOS, again, are going to be to correct those underlying hormone imbalances. It is not enough just to say my hormones are abnormal, I'm going to force ovulation to happen, but the hormone levels are still out of whack. We must correct those underlying hormone imbalances as well as optimize levels in order to improve not only your chances of pregnancy, but also to decrease your risk of miscarriage. We also need to make sure that with PCOS, we are correcting those ovulation defects. Again, as I mentioned, we need to make sure that you're actually ovulating, actually releasing the egg in order to be able to allow pregnancy to occur. And we want to make sure that as we're doing all of this, that we're reversing any underlying metabolic issues that are coming along with the PCOS. So as we've talked over the last few weeks, having insulin resistance or metabolic issues or excessive weight is not necessarily diagnostic of PCOS, but we know that it often runs hand in hand with it. So during this time, as we're balancing all the hormones, as we're looking at those ovulation defects, we want to make sure that we're addressing those underlying causes in order to help improve your overall health long term. Now, one of the other things that's really important to keep in mind with PCOS is that, yes, there are the hormonal and the metabolic disturbances, but there are also other anatomic issues that play a role when it comes to PCOS. So by definition, one of the criteria that some women with PCOS have is those excessive number of cysts on the ovaries or the enlarged ovaries due to unruptured follicles. Now, this makes it more challenging for new developing follicles to have space to grow as well as to rupture or to release that egg. And so the targeted therapy we want to use is, again, getting those cycles back on track. And sometimes surgery is recommended for women that have excessive amounts of cysts on their ovaries, either through an ovarian wedge resection or through cyst treatment of those excessive cysts on the ovaries. The other thing we know is that women with PCOS are 50% more likely to have additional endometriosis as well. Now, we don't exactly understand all of the causes for this, but we do know that endometriosis alone has an increased chance of fertility problems secondary to inflammation, blockages of the tubes, and this inflammation can prevent implantation. Now, importantly, as I've referenced in other episodes regarding endometriosis, this can be silent. And some women may not have any issues to let us know that endometriosis is a problem. For other women, endometriosis can be linked with painful periods, pain with intercourse, or GI disturbances like diarrhea or constipation during your period that can clue us into thinking there may be endometriosis playing a role. Now, at this point in time, the only definitive treatment for endometriosis is surgical evaluation with a laparoscopy and careful excision of those endometriosis deposits. There are different things from a standpoint of supplements and medications that can help to reduce the symptoms, but it is not going to actually remove or reverse endometriosis. So if you have inflammation alone, you may be able to get some relief from that. But if there are implants of the endometriosis, we are not going to be able to correct that just with medications or supplements alone. And that's really where the surgical evaluation and treatment comes into play. Now, one final note that I do want to make sure is important that you realize with this episode today is that IVF and IUI are not good treatments for PCOS. Yes, we can help people to get pregnant with those treatments. However, we still are not correcting the underlying problems. And so the ovulatory event that happens is a forced ovulation. We aren't correcting the underlying health and metabolic issues for mom. And so then we go on to still have those increased problems with miscarriage, with early deliveries, with problems with baby, and problems with mom throughout the pregnancy. So please know that just because you have PCOS, IVF is not the first-line treatment for you. It should not be the first-line treatment. It doesn't even address the underlying health conditions and issues that you're having. And I really just want to encourage women to look for a better way. And we have this better way forward with restorative reproductive medicine instead. So imagine if you could improve your chances of achieving pregnancy with a PCOS diagnosis while minimizing potential side effects and complications. This way forward is possible when you work with a healthcare professional who understands the importance of treating the root causes of PCOS to improve not only your long-term and short-term health of yourself and baby, but also to promote fertility. If you're ready to work with our elite team of healthcare professionals, go to our website, radiantclinic.com, to schedule a free discovery call with me and learn more about our package-based pricing for comprehensive care. We are currently able to see people for in-person appointments in our Cedar Rapids, Iowa clinic, or can arrange for a telehealth visit if you live in the states of Iowa, Illinois, or Minnesota. Thank you so much for listening to this episode. Please share this podcast with someone in your life who would benefit from our services. Remember to subscribe to this podcast for more empowering content that I look forward to sharing with you on our next episode of Cycle Wisdom.